Hi, everyone. My name's Baylee. I'm one of the general surgery interns, and today I have the honor of presenting the work done under the guidance of Dr. Karani. Our project is titled Durable Response to TVEC Therapy in Advanced Melanoma. By the way of background, TVEC therapy is an oncolytic viral immunotherapy in which a herpes simplex virus is genetically modified. It's currently the only FDA-approved intralesional therapy for melanoma and is often used in refractory melanomas. It's a really interesting mechanism in which there's both a local and distant effect. So for the lesion that you inject, there's selective viral replication in the cell that causes cell death. But then this also triggers an immune response and can have a great effect in distant lesions as well. In fact, the efficacy in clinical trials has been demonstrated as being 64% complete response in directly injected lesions and 34% complete response in indirect lesions, so those distant from the site of injection. And again, this is often in patients who have refractory metastatic melanoma to multiple lines of traditional therapy. You can see here an example of a patient who received injections to lesions on their extremity, and after 12 months, they had nearly no disease discernible. Although we have clinical trial data demonstrating the efficacy of these treatments, and there are ongoing studies even using it in the neoadjuvant setting, real-world data about this treatment are limited. So to that end, we aim to characterize the real-world use of TVEC at Stanford. We use it relatively frequently here compared to other sites, and we wanted to kind of see how we were using it in real practice. Sub-aims to that project were to look at the utility of post-TVEC tissue samples. Some patients in their practice pattern, the clinicians get post-treatment biopsies, scouting biopsies to look at the tissue after treatment. And some individuals go on to have oncologic resections after injections with TVEC, but others just watch this clinically. So we were curious whether those would be useful or not. And secondly, some patients, like I mentioned, go on to have full oncologic resections after complete response to TVEC. And we were curious if whether these direct injectables could be used as a definitive therapy for those who had complete response, or whether they really did need to go on and have an oncologic resection. And as you'll hear about a little bit later, and you heard about a little bit earlier, this is all part of a broader translational study to look for biomarkers that I'll get to. Our methodology was quite simple. We just did a single institution retrospective cohort study here at Stanford. We looked at pathology reports, clinical documentation, as well as imaging among the patients who received TVEC at Stanford. We collected a host of patient, tumor, treatment, and outcome data. And then we used simple descriptive statistics to describe our results. Our inclusion-exclusion criteria were quite permissive, given that these treatments are quite rare. The STAR database flags 68 patients as those who received TVEC. In the end, 3 of them actually didn't receive injections, and then 9 individuals were removed because they received TVEC therapy for other indications, 4 for Merkel cell carcinoma and 5 for squamous cell carcinoma. And we arrived at a group of 56 individuals who received TVEC injections for their melanoma. We found that, consistent with clinical trials and large other studies, that the vast majority of our patients were in their 60s to 70s with these refractory melanomas, although we do see patients as young as their 20s and as old as their 90s who received TVEC therapy. Pretty even distribution between men and women, but we did have more men receive TVEC injections at Stanford. Interestingly, we see that 75% of our patients had already failed checkpoint therapy. You may be wondering why this isn't 100%. There are ongoing clinical trials looking at TVEC in situ cancers, as well as early recurrences and in the neoadjuvant setting. And Stanford, as you can see in our real world data, is taking advantage of that, with 25% of our patients having not failed checkpoint therapy. They got injections all over the body, sometimes into skin, sometimes into lymph nodes. Similar to the checkpoint therapy, as you might imagine, most patients were stage 3C or higher, but we do have some of these earlier stage melanoma patients who are receiving it in the neoadjuvant setting. Most patients had had surgery before TVEC because they have an oncologic resection up front, recur, and then receive these treatments, but we did have a few who underwent oncologic resection after TVEC. Most patients had about 8 injections done over the course of a few months. Consistent with published literature, nearly half had side effects, usually fever, fatigue, malaise, sometimes nausea or vomiting, but very few patients had their treatment stopped or changed due to the side effects. And amazingly, of the 56 patients who received TVEC at Stanford, 25 individuals had a complete response to that therapy. Where there was post-treatment tissue available, we used pathology to say they had a complete response, but when they didn't, we used clinical documentation and images. And as you can see, only 2 individuals in each group required additional treatment after TVEC for their melanoma, and that would be salvage immunotherapy or additional radiation. So taken in whole, 45% of patients who received TVEC at Stanford had a complete response, and of those, 84% did not require subsequent systemic therapy, indicating a durable response. To answer this question of if we should be doing oncologic resections after complete response to TVEC therapy, I have a few case examples I'd like to show, given that the N in our study is small, given the rarity of this use. The first is a 33-year-old male who had stage 3 melanoma of the right posterior parotid, underwent an upfront excision and sentinel lymph node mapping, but then progressed on immunotherapy a few years later. You can see the progression here on an axial head CT that we see some avidity in the right posterior parotid. He underwent 6 cycles of TVEC to this area, then underwent a selective nodal dissection, and the pathology came back negative for metastatic melanoma. On his most recent screening PET CT, he had no evidence of disease in March of this year. Similarly, 67-year-old female who had an upfront excision for a melanoma of the right lower extremity. She then recurred, as you can see, on her axial PET CT right lower extremity. Similarly received 6 cycles of TVEC, and then a soft tissue mass excision, and it was negative for residual melanoma on pathology. And once again, in April of this year, no evidence of disease on her surveillance imaging. So overall, we demonstrate real-world use at Stanford of TVEC therapy shows an opportunity for response in the refractory setting, and this response is often durable in these patients who have had long, complicated clinical courses with their melanoma, but we still don't know how to best identify responders to this therapy. Do we need post-treatment biopsies after TVEC? Maybe. It's always better to have tissue, as Dr. Karani would say, but clinical determination may be sufficient in some cases to portend durable response. Is surgical resection necessary after complete response to TVEC therapy? You know, these are just examples, but of the 4 individuals who had a complete response to TVEC and went on to oncologic resection, 3 out of the 4 had no metastatic melanoma identified on their pathology reports, and the 4th had 4 out of 5 lymph nodes negative for disease. So compelling data at the very least. As far as our future directions, we're doing a multi-institutional clinical collaboration with the Cleveland Clinic, who also has about 50 patients who have received TVEC, and we're looking for best responders and use cases and practice patterns for this therapy that's relatively new. And the whole impetus to collect this data is born out of a translational study to evaluate the role of IFRA deficiency, which you heard earlier from Dr. Wagner, as a potential biomarker for treatment response. This is out of a paper that Dr. Karani published a few years ago in JCO, but we're looking for a biomarker. How do we know that TVEC will work in our patients? And while we don't know exactly what's triggering this immune checkpoint functional interactions, we see that there's a difference in responders and non-responders. And this signal shown through with even just 6 patients. So with this clinical data gathering and our collaboration with the Cleveland Clinic, we're increasing our samples by multiple fold and are starting to endeavor on a translational project to potentially identify a biomarker to tell us when are we going to respond to TVEC. Thank you.